What happens when COVID-19 and the seasonal flu affect our communities at the same time? Will our emergency services and hospitals be overwhelmed? Many are asking these very timely and important questions, and our guests on this week's Health Talk will address them, as well as other frequently asked questions about the seasonal flu and COVID. So stay tuned, we're up next. Hello, I'm Dr. Eric Mazer. Welcome to this week's Health Talk. Today we're going to talk about the influenza season occurring during COVID-19 pandemic. My guest is Dr. Benjamin Greenblatt. He's chairman of the Department of Emergency Medicine here at Norwalk, repeat guest to the Health Talk. He successfully led the Mission Health Day, recently sponsored by Norwalk Health, to provide free flu vaccines to the community. Why don't we start? Ben, welcome back to Health Talk. It's so good to have you.
Thank you, and thanks for having me back.
Tell us a little about Mission Day. I think that was great. I don't know if the hospital's ever done anything like that before. Tell us about that.
Sure. So Mission Health really, within the Nuvance health system grew out of a program that's been done up in Danbury, and it was our turn to sort of do this down in Norwalk. We had to, in all honesty, we had to pare it down a little bit. So, part of a component of Mission Health was to vaccinate the community and to provide flu vaccines. And what we were able to do in partnership with the EMS director, Jim Brubaker, who did a fantastic job, lending us equipment and getting the trailer out, and in conjunction and in collaboration with the Department of Health of Norwalk, the volunteers and the Department of Pediatrics, Dr. Briggs, we all came together, and pharmacy, and Bob Bepko and his team were fantastic with providing the flu vaccines and with the staff that we needed. And we took a morning and we went out to Norwalk and we set up, and we were able to.
So this was off the hospital campus?
Off the hospital campus, and we set up, and we had an extremely successful flu clinic, and I think that's it's a great step for the community, and it's more important than ever this year to do this.
These were provided free of charge, is that right, to the community?
That's right. Yeah. So we didn't ask for identification. We didn't ask for any insurance information. These are folks that just could come up and just feel free to get a vaccine.
How'd the community respond?
Well, that was we didn't know how they were going to respond initially, and it was hard to gather the data. But what we found very quickly was that they started texting each other, and what we initially
social media, and everybody shows up.
Exactly. So within, we initially thought 60 people would show up, and very quickly we had over 150 people, and it was very orderly. We had plenty of staff there. We had medical students. That was a great experience for them.
Do we have enough vaccines?
We had enough. Yeah. So we had enough vaccines, and that was great. So we vaccinated pediatric patients as well as adults.
That's a wonderful thing. Congratulations on doing that. Maybe that's a good segue though into why is it so much more important this year to protect yourself against the flu. We are in the midst of the COVID-19 pandemic. I guess we should point out that this is mid-fall, and we're beginning to see a second spike in Connecticut of cases. Maybe you could tell us a little bit why should we care so much about the flu? COVID is so much more important. At least it certainly scares us more.
So this has been a central strategy. When we talk, we are on weekly conference calls with the city, with Norwalk City, with the Department of Health, and with all the agencies in the city. So, and this is a strategy for our health network, and really a nationwide strategy. So it's hard to distinguish between the flu and COVID, obviously. So, I think even on a good year and without COVID, you want to make sure that as many people are vaccinated against flu as you can. But this year in particular, we don't know what the second surge is going to look like. We're just starting to see a trickling of cases starting to increase. So one of the things we want to make sure is that the health system is able to handle this surge. Right. And one of the things we want to make sure is that if you're not sick with influenza, that's less patients that need to come in. We can dedicate some more resources.
Because we know during the bad flu seasons, the EDs, I won't say get overwhelmed, but they certainly get quite busy. And you can see these dramatic spikes. A lot of people at home probably aren't used to looking at those numbers, but it's really, you see influenza spikes every winter. And some of them can be quite severe. And you start to think about combining that with a COVID spike, and then, healthcare resources begin to run thin.
Right, and that's been the fears. We have this, I've heard twindemic, they've called it, which is a COVID and a flu. Luckily, some of the data that we're getting, when we look at some of the southern hemispheres where the flu starts off before.
A lot of people don't realize, their winter, remember, is opposite of our summer.
Right.
So they've just come through their flu season, and they usually transport it from there to us. So go ahead.
Exactly. Yeah. So it rolls across the globe. Usually starts off in the east, and meaning Asia, and it gets through to Australia, South Africa, and South America. And this year, from what the data that we're seeing, is that it's been very, very low activity of flu. So we'd like to keep it that way, and that's one of the reasons we had the flu clinic here. And I suspect if we're doing everything that we've been doing with social distancing and masks and frequent hand washing, we should be okay. But I'm sure we'll see some of it.
I think it's really interesting that they've really had one of their mildest flu epidemics, I guess, in recent memory down there. And people are postulating it's not that COVID is protecting them against the flu, but that the same protective measures that we use for COVID, social distancing, the masks, we are socially distanced here, I should point out, for our viewers at home, that those same measures help protect against the flu. So hopefully, with the decreased travel and the decreased frequency down there, we'll have a mild flu epidemic, or flu season. Right. But hopefully, we're all going to get the flu shot. And I think particularly for people, I shouldn't say right now it's recommended for everybody, but particularly I think if you're an older person, if you've got diabetes or high blood pressure or any comorbidity, please get the flu shot this year. You're really protecting yourself. It's really important.
Yeah, no, I think that's a great message. I mean, really, I think the recommendations from the CDC is 6 months and above. So,
they use this to parse it out for pregnant patients and older, and now, as you said, it's everybody.
Right. So, I mean, and some of the things that we've done in the emergency department, and here at Norwalk Hospital, we've historically not done flu vaccines in the emergency department, but this has really been a game changer in terms of how we treat patients and what we do and how we serve the community. So last spring, as the flu was sort of petering off, that's when we just started doing flu vaccinations in the emergency.
Is this everybody who comes through who hasn't had a flu vaccine?
Who hasn't had a flu vaccine that wanted one? We're typically not. I would say we can be trained for it, but we don't typically ask those questions. Yeah. But we started to, get our staff and our nursing and our PAs and everybody just used to asking patients, would they like a flu vaccine?
How are patients receiving that?
I think they've been very receptive. It's convenient for them. I think one of the things that they want to see is make sure that their primary doctor or their the pediatrician for their child gets that information back. So
how are you guys handling that, guys and gals in the ED?
Yeah, so we've been lucky, with our EMR, when we print out discharge instructions, that will get they will actually get the report with them, and we'll be able to give that to them so they can give it to their PCP. If they're within the network, they'll actually see that an order was given for the flu. And for pediatric patients, we do like to call the pediatrician as much as we can, and we usually have that conversation with them.
That's great. And now you've lived through the initial COVID pandemic, or should say spike here in Connecticut. And from what I live up in the Hartford area, so we got it later in a sort of a flatter curve out there. So we never saw quite the overwhelming numbers that you saw down here. Maybe you could give our viewers at home what it was like on the front lines, because the ED really is the front lines of COVID. And let's talk a little bit about that.
Sure. So, I think one of the takeaways was that it felt in the very beginning that we were one step behind. We thought we were keeping up with all the information, but even as patients were coming in, there was confusion. Are we looking at the flu or are we looking at COVID? So that was difficult.
Yeah, without distracting you, because I do want to get to that. We talked about the flu and COVID being similar, and maybe you could, again, for our viewers, why are they so, or not, how are they so similar? And maybe particular also, how is it different from a cold? Because that seems to be what people are always confused about. Their nose starts running, they say, oh, I've got COVID. And that's really not what we're looking for most of the time. So how are they similar, and how specifically is that different from, the average upper respiratory virus that
Well, it can be very hard to distinguish. I know that, initially when we were looking at this, we said, COVID would have fevers and you'd have muscle aches or myalgias, as we say, shortness of breath. Later on, we learned that gastrointestinal symptoms were part of this, and that was part of sort of learning, about the disease. But that's very similar to influenza, where you can have, congestion, fevers, muscle aches, cough, obviously, so it looks very, very similar. And a lot of the other respiratory viruses, whether it's parainfluenza, coronavirus, or a rhinovirus, can look very similar too, with congestion and cough and fever. So, it's just a degree of, sometimes the low oxygen level, hypoxemia, as we say. We found that was very significant in COVID patients.
And somebody comes in complaining of respiratory symptoms. Well, what did you do at the beginning? Again, I'm really fascinated. What was it like at the beginning, and how have you changed things now so that we're better prepared now than we were back in April?
That's a big question, but there's so much that happened. I mean, if I look back, if I think back to what we were initially doing, we didn't know a lot. I think now we're in a much better position right now to deal with this than we were back then. Back then, we were just learning as quickly and and if you could get information from China or in Italy or where this was happening, you were trying to gather all that France, all this information in Europe, and you were trying to apply it here. So I think we're much, I think one message I'd get across it, we're in much better shape right now to deal with this. Obviously, if we don't get overwhelmed with a big wave. But, initially, we started to cohort patients. So one of the best practices in the emergency department was to bring in patients with respiratory symptoms, and we didn't know what they were, whether it was influenza, or whether it was a common cold, or whether it was COVID, and to bring them into one area of the emergency department that was well stocked with PPE, and everybody in there was prepared to see COVID patients. And everybody that came in there had a mindset that, had to be careful with these patients and see them all in there. So those were the first patients that we saw, and we wanted to make sure, we also wanted to limit aerosolizing procedures. So something that we do maybe, for the patients that have asthma or COPD or emphysema, we give aerosolizing nebulizers, and we stopped that, and we started doing just the metered dose inhalers that would minimize the amount of aerosolization that would happen. So
we only have a minute left for this segment. We're going to come back to all this.
Sure.
Maybe you could just, in the last minute, you told me before the show, virtually no one in the ED got infected and has gotten infected. We've only got a minute. How do you achieve that? And maybe that should reassure patients too, that they can come to the ED and it's a safe place.
Well, yeah, I don't want to jinx ourselves, but we were fortunate. We only one person got infected, and we did have a few people that we were quarantined in the very beginning. But yeah, I think just being paying attention to detail, having a high level of suspicion. So we didn't have that in the beginning when people were coming in, and we found out that it was a cough and a fever, and we're like, well, it's just a cough. So just having a high level of suspicion from the beginning.
So cohorting them, and then wearing the appropriate PPE.
Absolutely.
And on the part of the healthcare providers. This is really, we have so much more to talk about.
Yeah.
I think people want to know what it's like on the front line, what they can expect if they get sick, but we have to take a short break now. We'll be back in just a minute with Dr. Benjamin Greenblatt to talk more about COVID and the flu, especially that here in our community.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
Hi, I'm Dr. Eric Mazer. Welcome back to Health Talk. My guest today is Dr. Benjamin Greenblatt. He is the chair of the Department of Emergency Medicine here at Norwalk Hospital. And we're talking about a very timely topic, COVID-19 and the flu. It's the early fall, or mid-fall, and we're beginning to see an uptick in cases here in Connecticut. And we're talking about how we've learned so much from that first wave that you think we're much better prepared now. Right. So tell us more about that. Why, and let me even preface that by saying we're seeing an uptick in cases here in Connecticut. I asked you this before the show, but we're not seeing an uptick in deaths. And you think some of that has to do that we know so much more now? Or a lot of that has to do with that.
I think there's more to learn about COVID, certainly, but I think we're not in the position we were earlier. So, a lot of the information we had, and just because we didn't know, we had the lack of therapeutics. So we do have some options now to treat patients when they come into the hospital. We don't have anything as an outpatient yet, but certainly when you come in, if you're sick enough to come in the hospital, we have some medication that we can give you.
We've heard a lot about them. Maybe you can even mention them because people have heard about this on the street. Sure. Remdesivir is available to anybody that needs it here in the hospital?
Yes, we do have that available. Remdesivir is something that we've been using here in the hospital and throughout the network. We also have plasma if we need it, and maybe we can talk a little bit later about a plasma trial that we have going on in the emergency department. And we do have steroids. That's one of the components.
Yeah, people get mixed up on steroids because they think of bodybuilding steroids. Right. That's not the kind of steroids.
Yeah, not anabolic.
We're talking about dexamethasone,
right,
which is what they call an adrenal corticotropic hormone, right, or adrenal steroid, but it's it's one that reduces inflammation.
Inflammation, exactly. So, we have these oxygen therapy, which, initially, people tend not to think of oxygen as a therapy, but, it can be good and bad. And, initially the thinking was you would intubate people early.
Yeah, putting a tube down in.
Right, yeah, so we put them on a respirator, and, we came to find out that, maybe that wasn't so helpul. And then
I find that amazing that just simply, and I've read about this, you've lived it, I've only read about it, but simply the fact of putting a tube down late if they absolutely need it, not doing it preventively, and also putting people in different positions to help them get oxygen has made a big difference, hasn't it?
Yes. So putting people in different positions, something we said, proning people that we refer to help to sort of recruit a lot of the pulmonary lung tissue, the alveoli, but having that ability to do that and change that, but we didn't know that in the beginning. So we were doing different things, and there was a concern, if you recall, that were we going to have enough ventilators to do this, and that really focused us on this discussion: should we be intubating early or not? And there was a lot of data coming through social media and and just being on a lot of these blogs and finding out what other people were doing. I think helped to disseminate that information really quickly.
Yeah, that's also really new in the annals of medicine. Yeah. Is this national, it should say international discussion that went on during the COVID epidemic. Sort of you learn, well, you use your analogy. I loved your analogy. Why don't you use that for our viewing?
I can't take credit for it, but certainly as one of the things, information was changing so quickly, and we were that was one of the challenges actually, is making sure all the staff, the doctors, the nurses, the PAs, the techs, the secretary, everybody, and everybody in the hospital could keep up with the information. And we described it as we were sort of building the plane as we were flying it. So we were just getting along, and there were times when something that you put out early in the morning had changed by the afternoon, and you can imagine the challenges of trying to update everybody on the latest guidelines that we were coming out with. So it was frequent huddles in the emergency department, and I'm sure throughout the hospital, posting it on sites, emailing people about it. So frequent conference calls. We got, at one point, we were having weekly emergency conference calls to make sure everybody was up to date on what was happening and just going over the week's developments.
It really has been an amazing effort, which I think is bearing fruit again in terms of our mortality. We've gone through some of the medicines. I actually was impressed with what President Trump got. It sounds like they threw everything at him, and I don't mean that in an unkind way. He did get stuff early. Could I just ask you about some of the other ancillary things he got, and whether I noticed that he got famotidine, which is Pepcid. It's an antacid, and I know there's some marginal data, I guess, that it does. Do you use that or vitamin D or zinc or any of those adjunctive measures that I know he got and are out there?
We have not been using it here, so I think there's probably very little downside to vitamin D or Pepcid or famotidine.
I'll be honest, I take vitamin D because there's some data that it maybe is protective.
Right.
So, especially in the winter. So, those of you out there, 1,000 units a day. And as you said, the downside is almost non-existent.
Right. So, I think, we haven't been discharging patients from the emergency department with that therapy. But, I think one of the things that, as people come in, they may get famotidine. Patients that are hospitalized, sometimes it's sort of good just to give them a little bit of an antacid because there's a stressful situation to come into the hospital. So sometimes they get that anyway as they're going to the unit or something.
And let's talk about convalescent plasma, because convalescent plasma and these monoclonal antibodies that have been in the news, they all have the same sort of therapeutic idea behind them. So maybe you could talk about the trial and give us a little introduction to what antibodies are.
Sure. So the antibodies are molecules that your body makes to when you've come up against a virus or a bacteria or some other pathogen, and your body remembers it and puts out antibodies. So we've been able to take antibodies from other.
These antibodies are almost like little locks that, if you think that the germ is the key, they'll specifically bind onto that lock and help your body clear it from the system.
Exactly.
So yeah, go ahead.
Yep. So
I didn't mean to step on you.
It has the same. No, that's okay. It has the same structure as the antibody, and it locks in. So the plasma. So as patients started recovering from this, and this has been used previously in other type of conditions. They could take the plasma, analyze it to see if it had the antibodies, and then the thinking and the theory is that if you give it to patients, it would help them recover quickly. And and I'm glad you're asking me about this trial because quite proud of being an emergency department that's participating. The other emergency departments that are participating are Danbury Hospital and Vassar Brother, but Brown University here in the Northeast. And the trial is really a Johns Hopkins initiated trial, but it's a multi-center trial and being funded by the Department of Defense. And there's a huge, Operation Warp Speed that we're trying to get as much information as possible. But this particular trial is looking at patients that are not sick enough to come into the hospital. So this potentially would be for patients that could go home, and we're looking at two arms or two branches of it. So one would be patients that are COVID positive and with symptoms. So you would be randomized to get plasma that had antibody or potentially just plasma with no antibody.
So they don't know whether they're going to,
and
you
we
don't know either.
We don't know, and they don't.
So there's is it a 50-50 chance, or they?
Well, I think the randomization, yes, it could be 50-50. So the other branch of this would be, that same patient might have somebody in their house, or there may be somebody who's come into contact with somebody. So it's a high risk. So almost prophylactically giving this antibody, this plasma, to see if that makes any difference, and that's also randomized as well. We've had our first patient, so we're very excited about it.
That's a really exciting study. I think in particular, those of us who work with sick patients and viruses know that a lot of antiviral therapies are most effective early on in the disease.
Exactly.
And yet a lot of these tests that we do, we use them later in the disease. And I think it makes sense. At the beginning, you only want to expose somebody at great risk to a risky medicine. But now we're beginning to work into that world where can we catch it early? And I think we're likely to see more effectiveness of things like remdesivir and monoclonal antibodies and convalescent plasma in the early phase, so that our patients are going to have access to that. And that's really, really exciting. That is what Trump got. I mean, just for those who, I thought it was amazing how quickly he appears to have recovered with the antibody cocktail and remdesivir.
Right. No, you're absolutely right. I think you're right about getting it early. And I think one of the analogies I've heard from our infectious disease colleagues have been, remdesivir being, very similar to sort of Tamiflu, where you want to give it early on in the disease process in order to get the biggest benefit.
Yeah, with Tamiflu, what is it, 72 hours or 48?
Within 72 hours.
72 hours. If you don't give it within the first 3 days.
The challenge is that most people don't come in until they've been sick for a few days, so it's always.
But I think, that's, as we look forward, I think there's a lot of reason to be optimistic that the therapies alone, and then let's say a little bit about oxygen levels, because I think we've learned a lot about oxygen levels, and I must admit, I said before the show, I bought a home oximeter should I get sick, one of those little pulse oximeters that the athletes use to measure my own oxygen level, because they can be much worse than patients seem something peculiar about COVID. It could be so much worse than the patients seem to be.
Yeah, and that's been an extremely curious thing. When this first happened, I know we were talking a little bit about this before. I've never seen patients come in with oxygen levels so low, and that looks so good. Most of the, and at one point when we were sort of peaking here with COVID, our emergency department actually opened up what we refer to as a forward triage tent. And the idea behind that was that patients that were coming didn't necessarily have to come into the emergency department, and we could conserve PPE, they could get referred somewhere else. But with regards to that, what we saw was, just as short, they would park not too far away, and just that small, maybe 200-foot walk, and they would present to the tent, and we would get vital signs, and we would put the oxygen, and their oxygen levels were like down to the 70s.
Yeah.
And
remember, normal is up above 95, and the media made a big deal about President Trump being 93, but we're talking about people in the 70s, where usually they're pretty sick by.
You would be thinking of putting them on.
They are pretty sick, but they look sick by then.
Right, and and they're in distress, and we would be we would talk to these patients, and they said, no, I feel okay, and I'm like, and you would even, you would still bring them into the hospital, obviously, but you were surprised at how well, and there was a term early on that I'm not sure if it's still being used, but we'd call them happy hypoxic patients, so the happy hypoxic.
Sort of the black humor of medicine, because there's nothing to be happy about when you're that hypoxic.
Right. We were sitting around, we would be testing ourselves to make sure that the machine was actually working, because we couldn't believe how low the oxygen level was.
Maybe this brings up a good point for people at home. Since people may be sicker than they think they are, what should they do? If you get a fever and a cough, muscle aches, I guess certainly if you lose your sense of smell or taste, which seems to be quite specific for COVID, what should they do? What's the threshold to see somebody? Because they may not know how sick they are.
Right. So, one of the things that grew out of this, and it sort of kicked into high gear, was telemedicine. So, if there was, you're safe coming to the hospital, to the emergency department, I think it's a matter of deciding, how sick do you feel. So you do have some options. I think this go around, we're probably not going to have, the level of closures and the medical facilities and primary care offices that we saw. But people adapted, and primary care offices, I know our network adapted very quickly to telehealth. So that's an option for patients, is to call in, and there's things that they can do. Even though you don't have, let's say, a pulse oximeter at home, your doctor may be able to look at you, and if you have an ongoing relationship with your patient, you know them well, and you may ask, Mr. Jones, please stand up and walk a little bit.
We have less than a minute left. Yeah, that's these very hypoxic patients, when you stress them, have them walk up a flight of stairs or something do they get short of breath?
They did get short of breath after a while. Yeah, so after eventually.
So that may be something somebody could do at home if they suddenly find with minimal exercise they're very short of breath, even though they're comfortable in front of the TV. Right. Maybe they should have a higher index of suspicion that something's going wrong.
And I think call your doctor, and they may have different abilities to either talk to you on the phone or via telehealth, and and we're always here 24/7 available in the emergency department for everybody.
We got like 15 seconds left. I had also read and heard that patients can deteriorate very quickly. Do you want to say 10 seconds about that? That's heard about falling off the cliff, that people think they're fine, and next thing you know, they're very, very sick.
Well, yeah, I think that's true. So I think what we saw is later on, by day 7 and 8, a little bit later on, people got extremely sick, and that's when they were sort of presenting the emergency department, and they would deteriorate rapidly.
So that's really so. The first few days may be mild, and then again, that's why
they were holding off until the very end, because they were afraid to come for the emergency
Don't
department.
hold up. Boy, this is so informative and so helpful, and it's what's happening right here in our community. Thank you so much. Unfortunately, we're out of time. I'd like to thank my guest, Dr. Benjamin Greenblatt, for joining me on Health Talk today. Please send your questions and comments to us by contacting Health Talk at newvancehealth.org. It's been a pleasure talking to you today. Stay well.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.